Good morning. This chapter is going to cover psychological disorders, and I'm going to focus on two, in particular, schizophrenia and OCD. Before we start, I just want to make sure, and I'm going to read this verbatim, but this lecture and its contents are designed for educational purposes only. This information provided here should not be used for the purposes of diagnosing or treating a medical or psychiatric illness. The contents of this lecture includes text, graphics, and images about mental illness. Some content may be difficult to watch. Never disregard your medical advice from your doctor or other qualified health care provider or delay seeking it because of something you learned from this lecture. I urge you to seek the advice of your physician or other qualified health professional with any questions that you may have regarding a medical or mental health condition. In the case of an emergency, please call your doctor or 911 immediately. So I also wanted to post some resources for mental health. Since I live in Massachusetts, I mainly posted those, but the mentalhealth.gov services all of the United States, but basically any state would have the equivalent, but I wanted to focus on, I guess, Massachusetts because that's where I physically am. So every city has crisis services, but in Western Mass in particular, you can, CSO is a good, or the Clinical and Support Options, ServiceNet is a great one. If you or anyone you love or know and you have concerns about. And then NAMI, the National Alliance on Mental Health and National Alliance on Mental Illness, Massachusetts, is a great organization that can provide either reduced cost or free services to people who qualify for it. So, all right, so let's get started. We're going to talk about the difference between normal and abnormal behavior. And we're also going to talk about the major perspectives on psychological disorders used by health professionals, and talk about the major categories of psychological disorders. So defining abnormality is really looking at behavior. So, and the behavior that causes people to experience distress, meaning their lives are altered in a negative way. Their functioning is affected in their daily lives. So when we define abnormality, and this is where it's important in sort of understanding and using an operational definition of, so there's the deviation from the average, from the ideal, sense of personal discomfort, and inability to function effectively. So what comes to mind when thinking about functioning effectively is, can you work? Can you go to school? Can you just all of the things in our daily lives? So if we think about this developmentally, it would be different for a developmental or a childhood mental health illness, and than it would be for an adult. And it's also a legal concept. So I think the book does a really wonderful job of defining sort of perspectives on abnormality, and I wanted to show this. This is figure 1 from the textbook, and I'm not going to necessarily go through each one of them, but I wanted to sort of point out that the perspective on abnormality has there's not one perspective. There are different ways to view this, what is abnormal. So, for example, if you look at the medical if you look at the medical perspective right here, it assumes that the psychological causes are at the root of the psychological disorders. So, if Chris's case is the summary, the case study in the chapter, so that they would assume that Chris has medical problems, such as there's something wrong with his brain or a chemical imbalance, right? If you look at the cognitive perspective, that this is related, their behaviors are related to the person's thoughts and beliefs. So, an application would be that you need to work with Chris and his perception of his self and his environment. Behavioral, and we've talked about this with conditioning and learning, is that the behaviors or the abnormal behaviors are learned responses. So one way in applying this or treating this would be to focus on rewards and punishments for Chris, so that you would basically extinguish the abnormal behaviors and shape his behavior so that you would see more and reinforce the non-abnormal behaviors. But I do think that this this figure does a nice job of sort of laying out each one of the perspectives in the chapter. It's a very great summary. So, as I was saying, there's the medical perspective, and this one is, I would say that this is a pretty prominent, the medical perspective is a pretty prominent one currently, and especially within neuroscience. So, it's an application of what you learned about the brain and the neurotransmitters and connections in the brain, and so forth. And also when we learned about the endocrine system and the hormone imbalance and the thalamus and the hypothalamus and hormone regulation and so forth. All right. So this is I just wanted to present these slides to give you a summary of a little bit bigger text of the summary. But what I really like is that this from superstition to science piece of it, because as we learned in chapter 15 about personality, well, Freud was, his ideas now are considered outdated and radical. He did start a movement of thinking about how does our behavior reflect how we think about what determines our behavior and what determines abnormal behavior, and how can we start treating that. So, it's a little bit like superstition, because there was no way of empirically or testing a Freud's theories, because he did not necessarily have a testable hypothesis. So then we've talked about the behavioral, the cognitive perspectives. Humanistic, we talked about Maslow's hierarchy of needs earlier, in that in the motivation chapter, that you really need to have basic needs met before you can reach self-actualization. And so this is applying this one step further to understanding how behavior can be um, considered normal and abnormal based on what the needs of the person is and what needs have been met. Um, okay. So, how do you diagnose? Um, how do you diagnose mental illness? You use the DSM, and they just came out with a new edition, so it's 5. Um, and the diagnostic distinctions or criteria is that there are significant or major changes, and so the major changes to the DSM, and I think that this is sort of important. So the autism disorder has been reclassified, and this has sort of had a lot of repercussions in terms of how many diagnoses they have and the treatment options and so forth. Is that before there was Asperger's and autism were two separate diagnoses, but now it's just autism and it's a spectrum. Um, so I think that that's important. ADHD diagnosis has been renamed, and those are the most prominent ones I think that are important here. The major diagnostic criteria are, or categories, excuse me. I'll get my handy dandy pen out here. And I'm going to change the color real quick. Green. There's anxiety, somatic symptoms, dissociative, mood, schizophrenia spectrum. So those include a decline in functioning, thought, language disturbances, perception disturbances. So these are sort of defining what each one of these categories defines what is abnormal in their behavior. So we have a clear, if we think back to what is defining abnormal behavior, and there's a legal concept, and primarily the DSM is a medical perspective, so keep that in mind here. And now we are able to take that concept and apply it specifically to a type of abnormal behavior in a category that's caused by a certain psychological component that alters their behavior. So, for example, anxiety is a category of disorders for people who have anxiety that affects their daily functioning. But the DSM has clear symptoms of what anxiety is, so there's a clear operational definition of what the behaviors are and how they are abnormal or deviate from normal, typical behaviors. Okay. Other areas include personality. So I'm sure that, and I'm not going to display any political bias here, but I'm sure that you've heard that people are accusing Donald Trump of having narcissistic personality disorder, or that he's antisocial. So it's about to their functioning. And then there's sexual disorders, substance related ones. So, um, being basically a drug addict or an alcoholic, neurocognitive disorders. And we've talked about this before of when memory fails us. So Alzheimer's, um, I guess Korsakoff syndrome would be another one in here. Um, so I'm going to focus on OCD because I found some great videos that sort of that exemplify this. So, and this one is also often sort of misconstrued in society. So this is within the categories of anxiety, um, and it affects daily functioning. So we're going to talk about OCD. So OCD is characterized by obsessions or compulsions. An obsession is a persistent, unwanted thought or idea that keeps reoccurring. Compulsion is an irresistible urge to repeatedly carry out some act that seems strange and unreasonable, like checking the doors. And I think that the book, the videos I'm going to be using do a great job of showing this. And also, obsessive compulsive disorder means you need to have the obsessive tendencies and the compulsive tendencies. So I would like for you to watch the obsessive compulsive disorder video. So if you go to the chapter, um, when you're reading the chapter, um, there are videos and images that correspond to um, each chapter. And I'd like for you to go to chapter 15 and find the video. I can even try and post a link to see if you can find it. And there is a live case of what it's like to have OCD. And then there's also a TED Ed talk that I think that's great. That's about 4 minutes long, talking about the myths of OCD. So the next one we're going to talk about is schizophrenia, and that's a class of disorders where there's a severe distortion of reality. So characteristics include a decline from previous level of functioning, disturbances of thought and speech. So it's a formal thought disorder. They have delusions. They may have hallucinations and perceptual disorders. They have inappropriate emotional displays. They withdraw from society. So the primary courses of schizophrenia is the process. So I guess there's two onsets of schizophrenia. One of them is that the symptoms develop slowly and subtly. Another one is that they occur very sudden. And there's two types. So the symptoms and the display of symptoms, or presentation of symptoms, are type 1 and type 2. So type 1 is when you have positive symptoms of schizophrenia, and type 2 is when you have primarily negative symptoms of schizophrenia. So I can tell you a quick anecdote. I knew a family where schizophrenia was there had been several family members who had schizophrenia, so it was in the genetics, and the child, the boy who was my age, experimented with, I believe it was LSD, but hallucinogenic drugs, which ended up sort of activating his schizophrenia predisposition. So he very suddenly had reactive schizophrenia. And I believe he's doing okay now, but the drugs altered his chemicals, and then, it was full onset from there. So when we talk about, solving the puzzle, what is it? There, as I said, there are genetic factors. There could be structural abnormalities, biochemical imbalance. And what happened with the young man that I knew was that the drugs exacerbated the biochemical imbalance, and causes the schizophrenia. So my father actually did research in REM sleep, and he discovered with, as I say, his cronies, meaning his colleagues, that he had a hypothesis that people with schizophrenia had a dream-like state. So a dream-like state when they were awake, and that's why they were hallucinating. And so he was one of the first people to sort of disprove this theory, which was one of his major medical contributions to understanding mental illness. And then also, you have heard about so when treating Parkinson's disease, oftentimes there is a tricky balance of, because in Parkinson's disease they have too little dopamine, and so if they give them the drug L-Dopa, but they give them too much, they often will start exhibiting schizophrenic symptoms, and the medicine needs to be adjusted. There is a significant genetic factor in contribution to schizophrenia. So if you have an identical twin, and someone has schizophrenia, that the risk of developing it is 48%, which is pretty high. If two people who have schizophrenia are both parents to a child, that there's a 46 percentage. So genetics are one part of it, but not necessarily everything. So when we talk about schizophrenia, we think about the situational causes. And so this would be the environmental factors. So the genetics are the sort of nature part, but the nurture part. So, if someone has an interaction style that's, hostile or emotionally intrusive within a family, or the cognitive perspective takes the stance that over attention or under attention to stimuli in the environment. So, so the multiple causes of schizophrenia is the predisposition model, so that they inherit a predisposition and a sensitivity. The stressors are strong and are coupled with the genetic predisposition. They result in the appearance of schizophrenia. So when I think about the family friend who developed schizophrenia, the predisposition model is prominent here. So what I would like for you to do is go to chapter 15 in the electronic textbook, and it'll have there's the text, there's the pictures, and there is the videos. And I'd like for you to watch the video of schizophrenia and see. It's a very short video, but it's a man who has schizophrenia, and you can see sort of his delusional behavior. And that's it for this lecture, and thank you very much.